I would like to invite Dr. Darshana Heva Kandambi, who is the consultant in charge of the ICU Yang Chai Hospital in Hong Kong and also consultant to the ICU Princess Margaret Hospital, Hong Kong. Over to you, Darshana.
How do I get? Okay. Thank you. It's my pleasure to be here and share with you some of my experiences with ECMO and Impella. So I have a very difficult task of going through two devices in 20 minutes, and I can promise you I will not stick to time, but we'll try our best. Yeah, so this is Princess Margaret Hospital, one of the hospitals where I work. So what I thought I'll do today is walk you through with the circuit components of ECMO and Impella, and touch on some physiology as well. So first, just a brief look at the indications for temporary mechanical circulatory support devices. Broadly, I would say there are three categories. One is the cardiogenic shock group, where the majority of patients are AMI, acute myocardial infarction patients. Then the high-risk PCI patients, and also the ECPR, where we institute ECMO during the cardiac arrest. So that's called ECPR. So we have 4 devices available to us as percutaneous temporary mechanical circulatory support devices, IABP, tandem heart, Impella, and ECMO. IABP, I'm sure all of you are quite familiar. Touch on tandem heart. For the left ventricular support, there is a cannula inserted to the left atrium, and then blood is drawn and goes through a pump, a centrifugal pump, and return to the descending part of aorta. So as you can see, it has to be, the cannula has to be placed by puncturing the left interatrial septum. So it's a bit difficult procedure to be done and needs highly trained operators for this. The same device can be used for right heart support as well. It's a dual lumen cannula, and the end is inserted up to the pulmonary artery, and the blood is drawn from the right atrium. Now comes our main topic, ECMO. So this is not the way we do ECMO. It's a complete nightmare to transport patients like this. So this is a very famous picture of the first ever ECMO patients back in 1971. It's a young trauma patient with ARDS, and I'm not sure what type of ECMO they did. But anyway, he had, at least in the initial period, he had survived. So the reason why I put this picture here is for you to understand how the technology has improved over the years and how compact ECMO is now. And I hope that technology will continue to evolve and take us to a better place. So when we talk about ECMO, you may have heard there are two basic ECMO types. That is veno-arterial ECMO, which provides circulatory support, and veno-venous ECMO, which provides respiratory support. But the circuit is the same. There are only minor changes in the circuit, but all the equipment, the cannulas, maybe different sizes, but it's more or less similar. Where we insert the cannula is the difference. Is there a pointer in here? Oh, I can't find the point. Okay, all right, okay. So, so in the meantime, we'll continue. So for both systems, the drainage can. Oh, I see. Thank you. Hold on. Okay. So for both systems, the drainage cannula is inserted into the IVC, and the end is in the right atrium. So blood is drawn from the right atrium and also the IVC, and it just goes through the pump, the oxygenator, and the blood is in the VA ECMO is returned to the common iliac artery or distal end of the aorta. So that is a parallel system to the native cardiac system. And for the VV ECMO, the return line is in the internal jugular. I mean, this is a basic setup that I have put. There may be variations, but the basic setup is the blood is returned to the right atrium via the RIJ cannula. So it's a system that is in series with the respiratory system. Yeah. What are they? Ah, okay. Make it okay. All right. Okay. No, I prefer this one. Yeah. So this is in series with the lung. So, but today our focus is on VA ECMO. All right, so let's have a look at the components of ECMO. So you got the interface, the cannula, and the tubing. You got the pump. Then you got the oxygenator, and to the oxygenator there is the gas supply. Then the tube and cannula coming back, and then here there is a warmer. There are sensors in this system to measure variable parameters, and then there's the console where we interact with the system to change the flow. So this shows the drainage cannula, and this is the return cannula. So the drainage cannulas are longer because it has to travel a long distance, and it's bigger as well, so that the flow is good. And at the end, there is an opening. Apart from that, there are several other openings, so that the blood is not only drawn from the right atrium, but also from the IVC as well. The return cannula is much shorter, and the opening is at the end, and there is a side hole. So I'll show you the importance, the function of the side hole is in the later slides. So when we do it percutaneously, we use the Seldinger technique, similar to, say, putting CVH cannula. So as I previously mentioned, there is technological advances happening. When you put a patient on an extracorporeal circuit, it causes huge problems to the patient, the physiology, right? It leads to increased clotting, activation, increased complement activation, and so on. So to reduce this, the surface of these tubing I have not shown here, tubes and cannulas are having a homogeneous surface. And also the surface is coated with albumin to which heparin is attached. That helps to improve the lifespan of the whole circuit. And so this is a picture of a patient we had a couple of weeks back, showing you the groins, which is the usual setup for the VA ECMO. Immediately you can see that this is the venous limb and this is the arterial, because the color difference you can see that this is bright red. That means it has gone through the oxygenator. And this is a IABP. It's not related to the ECMO circuit. Now, in this picture, you can see the return line, and you can see something here. You may imagine what it is, because there is a big cannula in the femoral artery. It's going to compromise the blood supply to the lower limb. So to perfuse the lower limb, we put in another cannula called the reperfusion cannula distal to the insertion of the return cannula site. And then the circuit is, the circuit is connected via tubing. So the blood which is coming from the machine here, a little bit of blood will go through this circuit and then perfuse the lower limb. All right? Okay, so remember the next part is the pump. When the blood comes out of the drainage cannula, it goes through the pump. So pump, again, there is huge advances in this. The very first, not the very first, few years back, the pump were roller pumps, similar to the CVVH machines. But now most of the ECMO machines, I should say all, are having centrifugal pump, which produces a non-pulsatile flow. And then we adjust the flow by adjusting the revolutions per minute in the console, and then it can deliver up to 8 liters of blood. And one thing is that this flow is dependent on the afterload, say downstream. If there are any kinks, even if you set the same RPM, the flow will come down. And similarly, if the drainage blood has any problems, the flow will go down. Whereas opposed to the previous roller pump mechanism, if there is a downstream kink, it will still try to produce a flow at the same rate and even can lead to rupture of tubings. So this is, I guess it's a sort of more safe. So this is the machine that we use. Throughout Hong Kong, most of the ICUs are using this. I should say all, but there are other ECMO machines in the market as well. And this red part is what the pump looks like. Sorry. The pump is this one, the white one. Okay, so I told you that the flow that is produced by this pump is non-pulsatile. So this is the patient's arterial waveform. You can see minor pulsations. That's the patient's native heart pumping. I stopped the IABP machine to take this photo to show the flow produced by the ECMO machine. And this one I took after switching on the IABP. And you can see a nice pulsation coming after that. So next component is the oxygenator. So oxygenator is made up of a very thin material that is rolled up into tunnels like this, and inside the tunnels the gas will flow. Outside the tunnels the blood will flow, and the gas exchange will occur via diffusion. It's very efficient. And in the CardioHelp machine, the total surface area is, because of this structure, it's like 1.8 square meters. Yeah, so this is how the oxygenator looks like. And this is the inflow, and this is the outflow. This is the gas supply, and which is connected to the gas blender. And this is the warmer, the input of the warmer, connections of the warmer. Yeah, and so remember the first picture I showed you on ECMO, but this is how ECMO looks like now. So it's much smaller. And this is the picture of the warmer, which is placed below the machine, and yeah, there's the connection. I have 6 more minutes, and I have not even finished ECMO. All right. Yeah, these are the sensors, and this is the monitor. We change the RPM to change the flow. So there's continuous monitoring of the central venous oxygen saturation, hemoglobin, hematocrit, temperatures, and the flows. So this is the big picture. This patient also has the IABP in. And this picture has been taken like a few years back during an ECPR. And you can see the patient is on Lucas. And here I am cannulating, and I'm looking, what I'm looking at is the ultrasound machine, which is behind these two doctors. So we do cannulations via ultrasound guidance. And for the drainage cannula, after we put in the guide wire, we always check the subcostal view to look at the IVC and make sure that the guide wire is there. Okay, how about the physiological changes that happen with VA ECMO? So you can imagine we are giving blood against the heart. It's not the usual flow, which is not good, right? So that is going to increase the LV afterload, and it will, like it's a backflow, right? So then the aortic opening is reduced, the LV and diastolic volume will increase, the pressures will increase, the pulmonary capillary wedge pressure will go up, and so it's not a friend of the heart. I think only good thing for the heart is that it will increase the coronary perfusion. Apart from that, it's really not good for the heart, but it's good for your other organs. It's a friend of all your other organs except the heart. Yeah, so quick look at the pressure volume loop. I hope you can remember this. So in cardiogenic shock, it's shifted right and up. What does ECMO do? It shifts up further. And with the increasing flow, it will shift up further, right and up, which is not good. And the area under this denotes the myocardial oxygen consumption. So when it's shifted up and right, it will increase the myocardial oxygen consumption as well. So all are not good stuff for the heart, but we have to do it sometimes. Yeah, so I'll skip this because in view of the time, although these are also important slides, and go to Impella. Impella is a catheter that is inserted by the femoral artery in most cases and is placed across the aortic valve. And then the blood is drawn from the LV and ejected into the aortic root. For the left heart support and the ones that can be inserted via the percutaneous method, it's Impella 2.5 and Impella CP. Impella CP can go up to 3.7 liters per minute flow. For the percutaneous device, the right heart support is also there, Impella RP. And in that, the tip is placed in the pulmonary artery, and it sits across the pulmonary valve. So blood is drawn from the IVC and then returned to the pulmonary artery, letting the RV rest. These are larger Impella devices which need surgical placement. So, overview of the Impella setup. So, this is the end of the catheter, which is placed in the LV, and the catheter is inserted via the femoral artery. And then there's a sterile sheath similar to the IABP one. And then there are 3 ports. One is the pressure monitoring port. The other one is the controller. And another one is the purge system, which goes through the controller. Closer look at the end. So this part sits at the aortic valve, and this is in the LV. So the blood will flow from this inlet and will get ejected in the aortic root. And a closer look at this, but this is flipped, okay? So this is the LV side and this is the aortic side. So the blood will come from here, and this is the pump, the microaxial pump, and this is the motor. Yeah, so Impella is inserted usually by the cardiologist in the cath lab, and it's done under fluoroscopy, but although ultrasound can be used as well. But when the patient comes to ICU, we need to monitor the position of the catheter because it tends to get migrated at times. So what we do is echo, check via the echo. So echogenic part is from the inlet onwards. So the distance between the aortic valve and the inlet should be around 3.5 centimeters, although there is 5.5 centimeters further that you can't see with the echo. So what we see, one of the monitors would look like this. It shows the motor current, which is looking like a pulsatile waveform, and then this is the blood pressure. All right. So if you see the motor current is getting flat, that means it has moved. It has to have this pulsatile-looking waveform. So if you see this, then we need to see where it is. Has it gone in or come out? So you look at this. So this is LV pressures, right? So it has gone in, and here it has come out. It's in the aortic pressure, it has moved away out of the aortic valve and to the aortic root. So you can readjust it via ultrasound or fluoroscopic guidance. So the settings in the Impella are, there are power settings, power levels. So 0 is stopped and 9 is the highest. And according to the power level, the revolutions per minute will increase. And for Impella CP, the maximum achievable flow is 3.7 liters. So the third system is the purge system, okay? The objective of the purge system is to protect the motor, because the blood is ejected at the motor, and then if it gets here, it can get clotted and damage the motor, and it will not work. So blood is coming from here, and the purge system will purge continuously fluid, heparinized fluid, D5, from this end, and protecting the motor. So it can, that control is done by the machine. It's not done by us, and it can, it can go up to high pressures, the purging fluid. Okay. How about the physiological effects? So it's drawing blood from the LV out, right? So that's good. That's really good. And it's going to move the PV volume loop left and down. And not only that, you can see the shape has changed as well. That's due to the loss of isovolumetric contraction and relaxation, because there's continuous volume being drawn out of the LV. So it will unload the LV, reduce the left ventricular end-diastolic volume pressures. It will reduce the LV work, myocardial oxygen demand, and it's all good stuff. Increasing coronary perfusion, decreased pulmonary capillary wedge pressure. So this is just a summary, like a comparison. IABP is good. It's, the physiological effect is good. It moves left and down. Impella left and down. ECMO up and right. And ECPella. What is ECPella? ECPella is the combination of ECMO and Impella. So with ECMO, it's shifted up, and when you put an Impella, it will shift back down and left. So we do ECPella as well, because when we put the patients on ECMO, we monitor the left ventricular volumes and aortic valve opening as well. So this is one way that you can vent the LV during an ECMO run. The other methods are concomitant use of IABV, just like the picture I showed you, and also atrial septostomy. So I think with that, I will conclude my presentation. Thank you.
Thank you, Dr. Darshana. I would like to thank you for the comprehensive lecture on behalf of the Sri Lanka College of Cardiology. Now, I think the symposium is open for questions. Can you please?
Are there any questions from the house? I would just like... Cost of the Impella device and the operating.
Let me see. For Impella, it's more expensive. In Hong Kong, I think it's about 200,000 Hong Kong dollars per device, which is you have to multiply by 46. I don't know, in Sri Lankan rupees. So it's one of use, right? But ECMO machine, the cardio help, is about close to 1 million Hong Kong dollars, but it's used, right, multiple times. But of course, the oxygenator is one of use. Yeah.
I think I can help in the Sri Lankan context to make it a bit simpler. If we look at about a balloon pump, which is familiar to everybody, say if it's say $1,000 and Impella is 22,000 US dollars. The ECMO cost will be about 3,500 US dollars, but something which is with, no, I'm talking about the consumables. All that I have said is about consumables. Which something also I think we need to know, the companies will not like it, but we reuse the most expensive part of ECMO. So the pump head comes to about 8 lakhs, the oxygenator to about 3.5 lakhs. That is now. It used to be less. We reuse till everything falls apart. We cannot not do it. Companies may not like it. So that is where things are. So Impella is quite expensive. So I think, does that answer your question? Yes.
Just one question I'd like to ask from Jagati. Now you mentioned all the inotropes when it came to management of acute heart failure. How about the use of IV beta blockade?
I don't know about the cardiologist. I do use quite a lot of IV beta blockers to reduce the heart rate most of the time, and so I cannot say exactly when to use, but I normally look at the patient's ECG. So even in theaters, I do ST monitoring closely with multi-leads, like 12-lead monitoring I'll be doing. So when there is a ischemic evidence with the heart rate, I of course use IV beta blockers in those patients. But most of the time, what happens with the chronically impaired heart failures, people are reluctant to use IV beta blockers, thinking that all the guidelines like we should not use. But sometimes patients need heart rate to maintain in the very weak hearts. So in those cases, reducing the heart rate might be a problem. So that is what I normally go by, the echo finding, echoes, plus the, of course, if there is evidence of ischemia, I use beta blockers to reduce the heart rate. But if not, I normally get cardiologist view as well, whether it is worth reducing the heart rate. If it is useful, I will use IV beta blockers to reduce the heart rate.
And what is your opinion regarding the use of digoxin? Does it have a place?
I do believe on digoxin a lot, but cardiologists I'm working with are very reluctant to use digoxin. I use quite a lot of digoxin.
Are there any other questions?
When we keep on increasing the doses, at one point we are happy with the outcome and we want to wean down the inotropes. Do we just go on the reverse order, or is there any other way that we should do that, weaning of the inotropes?
Now, when I'm using the higher levels of inotropes, I normally monitor SVR and I use minimal invasive monitoring. PA catheters are not for us. I mean, in our setup, we don't use PA catheters. It's not available mainly. plus the working staff I'm with is not up to even registrar levels. So leaving a PA catheter in my units is a bit of a problem. So unless exceptional situations, I don't use, but instead of that, I'm using minimal invasive PICO mainly. So with higher inotropes, I normally I monitor SVR and other parameters like pulmonary congestion, all those parameters clinically as well as minimal invasive. They give parameters. So once they stabilized on the lactate levels, perfusion levels, so immediately next moment I start coming down. The how I come down depends on the parameters. Now, if they have high SVR, so I normally tend to come on vasopressors mostly, because I do see a lot of post-cardiac patients with vasoplegia as a cause of acute failure. So in those patients, I need to keep the SVR up by using the noradrenaline. But other than that, by using the parameters, so gradually I will come down. Whatever, I have no definite like protocol as such, but depending on the parameters, we can alternatively come down on inotropes.
Maybe I can add to that, because from ICU perspective, what we do is we monitor according to the mean arterial pressures, right? So you come down on the vasopressors gradually according to the mean arterial pressure. Usually we aim at, say, 65 millimeters of mercury. For hypertensive patients, you would have a higher target. So we just, it's simple. I mean, because we don't usually monitor with the pulmonary artery catheter, right? So yeah, I always go for simple stuff and more practical ways. So that is applicable to all.
Basically, use the map. That's it.
Yes. And also, of course, the lactates, and how the organ perfusion, not only the map. Of course, you have to look at the end organ perfusion as well, which is like we would regularly monitor lactate in these patients, which is an indicator of the organ perfusion.
Any other comments or questions? So, as there are no further questions, let us bring this symposium to a close. And let me thank both speakers for their very lucid presentations. And thank you for coming all this way to come and join us and enlightening us on some of the things, especially Impella, which we don't have and which we are unlikely to have in the near future till we have a slightly better economic climate.
I think I can talk a lot more. I just introduced the circuit, so
No, I
I don't think it should be used like very loosely. So.
Okay, so thank you very much, and just bring it to a close. And
that was a very enlightening session with a lot of new information. A big thank you to all the speakers and chairpersons.